Good day. Our session is about endocrine system function and sleep. I'm Dr. Bien Matawaran. I am an endocrinologist. These are my disclosures. And for this session, I was given 3 objectives by the scientific committee. One is to review the interaction between normal sleep and normal endocrine function. 2, to discuss the influence of endocrine abnormalities on sleep. And 3, to recognize the effects of sleep disruption and its associated endocrine consequences. The endocrine system is a group of specialized organs or glands that secrete hormones directly into the circulation. And these hormones are instrumental in growth, metabolism, and maintaining homeostasis. Similarly, sleep plays an important role in human homeostasis. Some hormonal secretion patterns are controlled mainly by the body's internal circadian pacemaker located in the hypothalamus within the suprachiasmatic nucleus, whereas other hormones are primarily affected by the sleep-wake state or cycle. Sleep and the endocrine system are closely intertwined. Sleep is a time of distinct activity in various endocrine systems. In addition, sleep quality and duration affect hormonal functions, such that sleep disorders and sleep fragmentation can contribute to endocrine abnormalities. Conversely, endocrine dysfunction can significantly affect sleep as well. Circadian rhythm and sleep-wake state controls hormonal secretion. So the primarily circadian regulated hormones include those produced by the hypothalamic pituitary axis, such as your adrenocortical hormone and your cortisol. This also includes your TSH or your thyroid stimulating hormone and your melatonin. Growth hormone, prolactin, and renin secretion are sleep-related. Sleep, especially slow-wave sleep, is associated with increased growth hormone releasing hormone, and ghrelin levels that we'll be discussing in detail later. As we go deeper in the relationship of sleep and hormonal secretions, it is important to take note of 2 major methods of sleep research in humans. And these are your sleep electroencephalogram and the assessment of sleep-related endocrine activity by collection of hormone profiles. The combination of these methods help to elucidate the interaction of sleep EEG and hormones in both normal and disturbed sleep. These studies showed a bidirectional interaction between EEG and endocrine activity. As an example, look at the illustration on the right. No, in a normal 25-year-old male, this shows control of hormone secretion as well as sleep patterns. During nocturnal sleep, there's 3 to 5 sleep cycles occurring in humans. And during the first half of the night, as you can see here, growth hormone surge is predominant, whereas ACTH and cortisol secretion levels are low. In contrast, during the second half of the night, as you can see here, ACTH and cortisol are high, while growth hormone is low. This pattern suggests a reciprocal interaction of the hypothalamic pituitary somatotrophic axis and the hypothalamic pituitary adrenocortical system, their peripheral endpoints of which are growth hormone and cortisol secretion respectively, and that you have a common regulator of the sleep EEG and nocturnal hormone secretion. So that shows you again the reciprocal relationship of these 2 systems. So just a short review, we will review what we call the hormonal feedback regulation. You're well aware that whatever stimulus or stimuli that comes that is perceived by the central nervous system will cause the release of hormones coming from the hypothalamus. And these hypothalamic hormones are usually named as releasing hormones or releasing factors. They will influence the anterior pituitary gland to secrete your trophic hormones that will eventually act on the peripheral tissues, like for example, the adrenal gland producing cortisol and the thyroid gland producing thyroid hormones. Once you have normal and physiologic levels of those peripheral hormones, you now produce a negative feedback inhibition to the hypothalamus to reduce circulation or secretion of hypothalamic hormones, as well as a shortened loop negative feedback inhibition to the anterior pituitary to again halt further secretion of those hormones. For this session, we'll be talking about two important hypothalamic pituitary systems. One is the hypothalamic pituitary somatotrophic system, and the next is the hypothalamic pituitary adrenocortical system. As you can see in the illustration on the right, okay, in the hypothalamus, growth hormone releasing hormone will stimulate the release of growth hormone as you go see here. Okay, growth hormone secretion is bipolarly regulated because your SRIF or your somatotropin release inhibiting factor, also known as your somatostatin or your growth hormone inhibiting hormone, will of course inhibit secretion of growth hormone. So these two very important hypothalamic hormone will bipolarly regulate secretion of growth hormone. And this is of course affected by sleep. Eventually, in the anterior pituitary, growth hormone will be secreted and eventually act peripherally to the liver, to the chondrocytes, and to the other peripheral tissues with the help of your IGF-1 or your insulin growth factor 1. On the other hand, we also have the hypothalamic pituitary adrenocortical axis. So just like the growth hormone axis, we have the CRH or the corticotropin releasing hormone, okay, from the hypothalamus that will eventually stimulate secretion of your ACTH or your adrenocorticotropic hormone, also known as your corticotropin, to eventually act on the adrenal cortex, primarily in the zona fasciculata to secrete your cortisol. So again, once you have physiologic levels of cortisol, there will be a short loop and a long loop negative feedback inhibition to suppress secretion of CRH and ACTH respectively. This illustration, these figures illustrate the diurnal rhythms in human hormone secretion. On top is corticotropin releasing hormone. We've discussed this earlier, coming from the hypothalamus, and the eventual release of cortisol in response to CRH and ACTH secretion. We'll be discussing in greater detail later leptin, which is a very important anorexigenic hormone. We'll also be discussing melatonin, which is very much associated with sleep, and also thyrotropin or your TSH. The hypothalamo-pituitary adrenocortical system or the HPA axis mediates the reaction to acute physical and psychological stress, as you can see here. This stress reaction starts with the release of CRH from the hypothalamus from the parvonuclear cells. This results in the secretion of ACTH from the anterior pituitary and finally in the secretion of cortisol from the adrenocortical complex. Various cofactors contribute to this cascade. Okay? And this axis is affected also by circadian rhythm as well as sleep. The hypothalamic pituitary adrenal axis is primarily under circadian rhythm control. So as you can see here, the broken line is represented by your ACTH coming from the anterior pituitary, and the solid line represents cortisol coming from the adrenal cortex. Cortisol and ACTH levels peak in the early morning and decline during the day. With that being said, secretion of ACTH and cortisol is weakly modulated by the sleep-wake cycle because it is primarily regulated by the circadian rhythm. Sleep onset is normally associated with a decrease in cortisol, as you can see here, and the nadir levels of cortisol and ACTH levels occur during the first part of sleep. The primary circadian control is evidenced by the fact that daytime sleep does not significantly inhibit cortisol secretion. So that when you expect a peak or a an increase in cortisol in the morning, even if you do sleep at this time, you don't see a blunting of the cortisol response. So this diurnal variation in cortisol secretion persists even when sleep is altered and is not significantly affected by the absence of sleep or by sleep at the unusual time of day. The 24-hour periodicity of your corticotrophic activity is therefore primarily controlled by circadian rhythmicity than by sleep. This illustration shows the schematics of sleep impacts on the HPA axis. Slow wave sleep, as you can see here, is inhibitory to the hypothalamic pituitary axis, while the REM sleep stimulates cortisol production. Corticotropin-releasing hormone, as you can see here, has been shown to stimulate wakefulness, while exogenous intake of glucocorticoids have been shown to counteract this effect and stimulate sleep by feedback inhibition. How about TSH? Thyroid-stimulating hormone is primarily under circadian control, but is significantly influenced by the sleep-wake cycle. During daylight, TSH levels are low, as represented by the graph. Starting in the early evening, TSH levels increase quickly and peak shortly before sleep onset. Sleep inhibits TSH levels from increasing further. Therefore, sleep has an inhibitory effect on TSH secretion, most notable during the slow wave sleep. During the latter part of the sleep period, there is a progressive decline in TSH levels, and the circadian effect on TSH secretion is predominant with some influence from sleep. For example, sleep deprivation results in higher TSH levels during the night because of the lack of sleep's inhibitory effect. But this inhibitory effect of sleep on TSH secretion seems to be dependent on the time of day because daytime sleep does not seem to have the same suppressive effect on daytime TSH secretion. So again, though sleep modulate most of those hormones, circadian rhythm primarily regulate hormonal secretion for those hormones that I mentioned earlier. Melatonin, on the other hand, is released, is controlled by the light-dark cycle and the suprachiasmatic neuron in the hypothalamus through a series of complex polysynaptic pathway. It is produced and released from the pineal gland directly into the blood and cerebrospinal fluid. Melatonin levels start to increase in the evening and peak in the early morning. Melatonin is postulated to promote sleep by decreasing the firing rate of the suprachiasmatic neuron, and its production is suppressed by exposure to bright light. How about those hormonal secretion that is primarily sleep-related? So we have your growth hormone, your prolactin, and your renin secretion. So the hypothalamic pituitary somatotrophic axis, particularly growth hormone, stimulates tissue growth and protein anabolism. These effects are mediated in part by your IGF-1 or your insulin growth factor 1. The synthesis and secretion of growth hormone are promoted by your GHRH or your growth hormone releasing hormone and inhibited by your somatostatin or your SRIF. Secretion is largely influenced by sleep, and growth hormone secretion increases during sleep with less influence by the time of day. So again, this is mostly sleep-related than circadian rhythm. The major peak of growth hormone secretion during the 24 hours occurs after sleep onset, in rather strict but not absolute association with the first period of slow wave sleep. The amount of growth hormone secretion closely correlates with the duration of stage 3 sleep, and growth hormone secretion appears or is suppressed during sleep deprivation. So this is very important that anytime you have sleep deprivation, growth hormone secretion is suppressed. However, in sleep-deprived but relaxed normal young males in supine position, an unchanged nocturnal growth hormone peak is observed. So that even if you're not sleeping, but you're rested, no, or supine, especially among young males, you also still expect a growth hormone secretion. Ghrelin, on the other hand, is also important as a modulator for growth hormone secretion. Ghrelin is produced by the stomach, and it is often called as your hunger hormone. It is a potent endogenous stimulus for growth hormone secretion by binding to the growth hormone secretagogue receptor. In this graph, as you can see, when patients were given ghrelin and hexarelin, which is also a growth hormone selective agonist, you see the peak or an increase in growth hormone secretion. It has been found out that lack of sleep can trigger increased levels of ghrelin and decreased levels of leptin. Ghrelin is the hunger hormone, while your leptin is the anorexia hormone. Okay? So that when you lack sleep, what happens is that you will actually increase hunger and decrease satiety, leading to increased eventually risk for metabolic syndrome and diabetes mellitus that we'll be discussing in detail in pathology. So the major peak of growth hormone secretion during the 24 hours occurs after sleep onset, as you can see here, in rather strict but not absolute association with the first period of slow wave sleep. When growth hormone concentrations are determined every 30 seconds in the normal young males, maximal growth hormone secretion is found within minutes of your onset of your slow wave sleep. However, growth hormone may be released before sleep onset in normal males, and in women, a pre-sleep growth hormone surge and one or more additional growth hormone peaks are characteristically found. So a close temporal relationship is found between growth hormone secretion and slow wave activity. Prolactin, on the other hand, which is also known as your lactotropin, is a protein best known for its role in enabling mammals, usually females, to produce milk. Prolactin secretion is strongly linked to sleep. Levels increase shortly after sleep, as you can see here in green, regardless of the time of day. Although this stimulatory effect is greatest at night, during nocturnal sleep, the PRL levels peak around the middle of the sleep period, and awakenings associated with sleep disruption eventually inhibit nocturnal prolactin secretion. Therefore, the secretion of prolactin is mainly sleep dependent. So that when we request for prolactin test, we ask our patients to actually be awake for a few hours or so to make sure that there are no false elevations in prolactin levels. How about normal secretion of gonadotropic hormones, meaning your LH and your FSH? So secretion seems to have both circadian rhythmicity and sleep influences, as you can see in the slide. Gonadotropin-releasing hormone coming from the hypothalamus controls the secretion of your luteinizing hormone and your follicle-stimulating hormone. So the luteinizing hormone is responsible for eventual stimulation of testosterone secretion in men, and the FSH is for the eventual spermatogenesis also in men. The 24-hour pattern of gonadotropin release and gonadal steroid levels vary according to gender and stage of life. There's an increase in LH and FSH at sleep onset in children. It is also noteworthy to note to say that testosterone production varies diurnally, but its production depends directly on sleep. So we expect an increase in testosterone at sleep onset and the maximal levels early in the morning. So so that immediately after waking up from rapid eye movement, there is an increase in this hormone alone may actually cause a morning erection. And that is even in the absence of physical stimulation. So that shows you the effect of sleep with regards to increased testosterone secretion upon waking up. How about the renin-angiotensin-aldosterone system? So some circadian rhythmicity occurs in the RAS, in the renin-aldosterone-angiotensin system, with more urine flow and increased electrolyte excretion occurring during the day. Increased renin and aldosterone levels during sleep decrease urine output, and plasma renin activity is synchronized with non-rapid eye movement and rapid eye movement cycles. There's actually higher levels occurring during the NRM sleep, and the lowest levels occur during REM sleep. Therefore, there is decreased urine flow and increased urine osmolality that occurs during REM sleep. Sleep deprivation, however, decreases the usual elevation in aldosterone levels occurring during sleep, which results in increased sodium excretion. So there are also hormones that affect energy balance that will eventually be modulated by sleep. Sleep plays an important role in energy balance, as we all know. Both sleep and circadian rhythm control leptin secretion. Leptin is a hormone that is primarily secreted by the adipocyte that promotes satiety, or what we call an anorexigenic hormone. And this will also increase metabolism. Okay, so that in patients who are obese, they have high levels of leptin, and this is because of what we call leptin resistance. Level fluctuate in response to caloric balance and increase at night. You expect a peak at around 2:30 a.m. of leptin and nadirs in the early afternoon of around 1 p.m. This nocturnal elevation of leptin levels is thought to suppress hunger during sleep and may increase slow wave sleep. When controlling for nutrition and activity, a shift in nighttime to daytime sleep results in leptin peaks during both day and night. Ghrelin, on the other hand, is secreted from the stomach, and it stimulates appetite, or as I've said earlier, a hunger hormone that eventually promotes weight gain. So release is controlled more by sleep-wake circadian influences. Typically increases during the first half of the night and decreases in the second half, even when fasting. It also enhances growth hormone secretion, as I've said earlier, and may stimulate slow wave sleep. So these two opposing hormones are very important for energy balance. How about the effect of sleep on insulin and glucose? So there's a complex relationship between sleep, insulin, and glucose control. Decreased glucose tolerance is noted during sleep, whether sleep occurs during the nighttime or at daytime. This occurrence is thought to be related to decreased brain glucose use, decreased muscle use and tone, and anti-insulin effects of growth hormone. Although glucose metabolism occurs during non-REM sleep, increased glucose metabolism occurs during REM sleep and wakefulness. Improved insulin sensitivity seems to occur at the end of sleep, and this seems to occur due to improved glucose control at the end of the night, and is thought to be due to multiple factors, including increased metabolism during REM and wake time, greater body activity, augmented non-insulin mediated glucose removal, and action by previously secreted insulin. So as you can see, most of the time, glucose tolerance is decreased during sleep. So what now are the effects of endocrine abnormalities on sleep? So if you have a patient with endocrine abnormality, what will now happen to his sleeping patterns? So we'll start first with acromegaly. So as we all know, acromegaly results from excessive growth hormone production, in addition to notable physical findings such as elongated digits and coarsening of the facial features. There are several morphologic changes that can predispose to sleep apnea. So these features include soft tissue changes such as macroglossia, or enlargement of the tongue, elongation and thickening of the soft palate, swelling and thickening of the pharyngeal walls, and thickening of the true and false vocal cords, which result in pharyngeal airway narrowing and an increased risk of airway collapse. So that is why patients with acromegaly may suffer from sleep apnea. There are also bony changes. You have more vertical bony growth of the face, resulting in posterior placement of the tongue. Thus, there's narrowing of the pharyngeal air spaces. A more inferior position of the hyoid bone may also contribute to upper airway instability. So as you can see, those changes in the viscera, visceromegaly, as well as in the muscles, in the soft tissue, and in the bones will predispose the patient to develop sleep apnea. However, we also have to consider that these patients may have sleep apnea due to both central and obstructive causes and even may suffer from narcolepsy. An Australian study found a high prevalence of sleep apnea in acromegalic patients, with approximately 60% of the patients with acromegaly having sleep apnea. The same research found out that 33% had sleep apnea, central sleep apnea, possibly due to an increase in the hypercapnic ventilatory response. The prevalence of sleep apnea remains high even after treatment of acromegaly, though improvement with transsphenoidal sinus surgery with or without radiation may occur. However, uvulopalato-pharyngoplasty has not been shown to improve obstructive sleep apnea in patients with acromegaly. Octreotide, which is a somatostatin analog that will inhibit growth hormone secretion, has also been demonstrated to improve sleep disordered breathing. Central sleep apnea seems to persist despite intracranial resection with or without radiation with treatment of acromegaly. So what are the effects of abnormalities in thyroid hormone secretion to sleep? So hyperthyroidism and hypothyroidism. So both hypo and hyperthyroidism can cause or exacerbate sleep disorder such as obstructive sleep apnea, insomnia, and hypersomnia. Both hyperthyroidism and overdose of thyroid hormone supplements have been associated with insomnia. Hyperthyroidism had been more typically associated with difficulty of falling asleep rather than maintenance insomnia. Thyroid excess may also contribute to restlessness with a higher prevalence of restless leg syndrome, which in turn may exacerbate insomnia complaints. On the other hand, symptoms of hypothyroidism overlap with those symptoms of obstructive sleep apnea and may be difficult to distinguish. OSA may be a consequence of hypothyroidism, and up to 50% of hypothyroid patients have some degree of sleep disordered breathing. So it's very important that for your patients suffering from hypothyroidism that you check for obstructive sleep apnea. And likewise, those patients with OSA should be checked for hypothyroidism, because hypothyroidism can potentially exacerbate or cause obstructive sleep apnea, including excessive weight gain, reduction in ventilatory drive, thyroid myopathy, and abnormal mucopolysaccharide content in the upper airway tissue. The presence of goiter in patients with hypothyroidism, independent of any concurrent hypo or hyperthyroidism, has occasionally been reported as a cause of obstructive sleep apnea due to mechanical constriction of the upper airway. Thyroid hormone replacement may be important as part of treatment. Evidence varies and it's conflicting with regards to improvement in sleep disordered breathing, because in some studies, thyroid hormone replacement has been shown to improve sleep disordered breathing in hypothyroid patients with OSA. In patients with sleep apnea and hypothyroidism, it is recommended the treatment of sleep apnea be started first until thyroid replacement has been achieved, because of reports of angina patients initiated on thyroid replacement before management of sleep apnea. So treat the OSA first before more aggressive treatment of hypothyroidism. So the illustration shows us the symptoms and signs of hypothyroidism. Okay. The angina that usually occurs after initiation of treatment resolves with initiation of continuous positive airway pressure therapy. So we'll now go to the effect of hypothalamic pituitary adrenocortical axis disorders to sleep. So adrenal insufficiency and Cushing syndrome. too little and too much cortisol. So adrenal insufficiency, primarily due to deficient cortisol secretion, results in severe fatigue, sleepiness, and poor quality sleep. These symptoms may persist even in patients who are on treatment. Sleep-wake disorders, on the other hand, has also been attributed to patients with elevated cortisol levels or Cushing syndrome, chronic insomnia, or probably bidirectional in patients with Cushing syndrome, but suggests that elevated cortisol levels may contribute to chronic insomnia in patients with Cushing's or hypercortisolism. This illustration shows us normal pattern of cortisol and ACTH secretion on the left, while we see on the right plasma concentration of ACTH and cortisol in patients with Cushing syndrome. We see now that there is an indistinguishable pattern of circadian variation in secretion of both ACTH and cortisol. So Cushing syndrome and sleep, there's limited information concerning a possible link between Cushing syndrome and an increased risk of obstructive sleep apnea. 18 of 22 patients demonstrated a respiratory disturbance index of 17.5 points, which is moderate, okay, OSA. A link between exogenous corticosteroid therapy and sleep apnea also is recognized. And a well-known complication of corticosteroid therapy include issues with insomnia, in addition to other neuropsychiatric issues. So that a patient with Cushing syndromes may also be harboring abnormalities with regards to sleep. Testosterone. Okay. Low testosterone or hypogonadism often note a lack of energy or fatigue. There's decline in sleep quality after middle age and with increasing age in men. So this is the usual pattern that we see with regards to growth hormone to testosterone secretion. Decreased testosterone may lead to increased fat mass, and there may be poorer sleep quality associated with obesity. Estrogen and progesterone, on the other hand, is altered during menopause. There will be alteration in mood, hot flashes, insomnia, and an increased prevalence of upper airway instability. This is more likely to manifest with obstructive sleep apnea, even when corrected for BMI and age. So what are the melatonin effects on sleep? So direct sleep, melatonin plays a role in regulation of human sleep, as we all know. And in addition to its direct sleep facilitating effect, melatonin may improve sleep through a chronobiotic effect by entraining the circadian system to a desired sleep-wake cycle. We know also that exogenous melatonin decreases sleep latency, and the sustained release and transdermal formulations can actually increase total sleep time and sleep maintenance. Doses of oral melatonin of 0.3 to 5 milligram doses improve sleep efficiency in healthy people during the daytime when endogenous melatonin production is absent. As you can see, there are conditions that will affect those endocrine conditions that will affect sleep health. Okay. We now go to the effects of sleep disorders on hormonal regulation. We'll start with sleep deprivation. So it is common in industrialized countries that insufficient sleep may occur as a result of voluntary sleep restriction, insomnia, or shift working. Decreased sleep is associated with increased risk for obesity, diabetes, and hypertension. So what are the effects of sleep deprivation to the adrenocorticotropic hormone and cortisol? So sleep deprivation results in elevations of evening cortisol levels, and this conversely results in a significant reduction of cortisol secretion the next day, which seems to be related to an increase in slow wave sleep during the recovery night, which exerts an inhibitory effect on the hypothalamic pituitary adrenal axis. The amplitude of normal circadian rhythm decline in cortisol levels is reduced with insufficient sleep. So you don't see the peaks and the troughs of normal cortisol secretion with sleep deprivation. On the other hand, sleep deprivation with regards to its effect on insulin and glucose metabolism has been widely looked at. Insulin, this interaction between sleep, circadian function, and glucose metabolism has been evaluated, and both sleep insufficiency and sleep fragmentation have been linked to abnormal glucose metabolism through a direct effect on insulin sensitivity. It has been shown that sleep restriction affects glucose tolerance. Approximately 20% reduction in insulin sensitivity is seen without simultaneous increase in insulin levels. So this will translate to a reduced glucose tolerance and an eventual risk for diabetes mellitus. So the association of short sleep duration, meaning less than 6 hours per night, is of course seen with regards to an increased risk of diabetes mellitus. So that is why the American Association of Clinical Endocrinologists in their 2021 comprehensive guidelines for management of patients with diabetes included sleep as one of the important parameters for non-pharmacologic management of patients with diabetes. As you can see, it is recommended that diabetics should get about 6 to 8 hours per night of sleep. Make sure that you practice basic sleep hygiene. You also may need to screen sleep disturbances and do home sleep studies for those patients, especially suffering from obstructive sleep apnea, and may eventually see or need to see a sleep specialist. So how about the effect of sleep deprivation to leptin, ghrelin, and appetite regulation? We've discussed earlier that leptin as a hormone promotes satiety, whereas ghrelin promotes increased food intake and reduced fat metabolism. Partial sleep deprivation is associated with significant decreases in leptin levels and conversely increased levels of ghrelin. So when you are sleep deprived, you actually increase your appetite, no? And actually make you be hungrier. Okay. In the Wisconsin sleep cohort study, limited total sleep time was associated with higher ghrelin or your hunger hormone and reduced leptin levels, which is your satiety hormone. And this translated to increased food intake due to an internal misperception of insufficient energy availability. What are now the effects of insomnia? So insomnia refers to the inability to sleep adequately, either in length or quality, despite the opportunity to sleep. And this is to differentiate it from sleep deprivation that we discussed earlier, which refers to curtailed sleep length due to an externally imposed restriction of the opportunity to sleep. So in insomnia, you have the opportunity to sleep, but you can't. While in sleep deprivation, you actually don't have that opportunity to sleep. So insomnia affects the adrenocorticotropic hormone and cortisol because overall and sustained increase in ACTH and cortisol secretion occurs with insomnia, although maintaining the normal circadian pattern. Chronic activation of the HPA axis, no, high cortisol, high ACTH, places patients with insomnia at risk of significant medical morbidity. The effects of insomnia to insulin and glucose metabolism, particularly because of sleep fragmentation, results in abnormal glucose metabolism, especially if with associated suppression of the slow wave sleep. Risk of type 2 diabetes was found to be almost 3 times higher in subjects with insomnia, those with sleep duration of less than 5 hours versus those with longer sleep duration. So that again tells us how important sleep is with regards to glucose metabolism. Another sleep disorder is obstructive sleep apnea, which also affects, of course, insulin and glucose metabolism. The link between OSA and impaired glucose tolerance or metabolism due to insulin resistance seems to occur independently of obesity. So even if you have type 2 diabetics that are not obese, no, there's still a link, no, between OSA and impaired glucose tolerance. or impaired glucose metabolism. The severity of OSA is associated with increased insulin resistance. You have increased apnea-hypopnea index that has been associated with worsened glucose tolerance and insulin resistance. The primary postulated mechanism is that this is a consequence of sleep fragmentation with diminished slow wave sleep. And this actually enhances sympathetic activity, endothelial dysfunction, and impairment of peripheral vasodilation. Insulin resistance may contribute to the metabolic syndrome eventually. So that is why it is very important to address obstructive sleep apnea. How about the effect to metabolic syndrome? Patients with OSA seem to be at higher risk of developing certain features of metabolic syndrome. So that includes, of course, hypertension, insulin resistance, and type 2 diabetes. So the metabolic syndrome is basically a complex metabolic syndrome, a complex condition characterized by several metabolic conditions. 3 out of the 5 usually characterize a patient with metabolic syndrome, meaning with abdominal obesity, elevated triglyceride, low HDL cholesterol, high blood pressure, and increased glucose levels. Metabolic syndrome patients is more likely to be present in patients with obstructive sleep apnea. Patients with OSA are often obese and have a heightened sympathetic drive, endothelial dysfunction, systemic inflammation, insulin resistance, hypercoagulability, and high plasma leptin levels, which are all secondary factors associated with metabolic syndrome and even diabetes mellitus. So this is a summary of the pathway linking sleep insufficiency and fragmentation to abnormal glucose metabolism and type 2 diabetes. As you can see, with short sleep duration and sleep fragmentation, there is a reduction in brain glucose utilization. There is an increase in sympathetic activity, altered rhythm of both cortisol and growth hormone secretion, and an increase in inflammatory markers and abnormal adipocyte function. This will eventually also accompanied by reduction in beta cell function. So there's no corresponding or reciprocal increase in beta cell secretion because of or in spite of increased insulin resistance. And this increased insulin resistance results from a low leptin and an elevated ghrelin, producing increased appetite with minimal change in energy expenditure, thus driving obesity and eventually hyperglycemia or worsening hyperglycemia in patients with type 2 diabetes. Another sleep disorder that may affect hormonal secretion is circadian rhythm disorders. So circadian misalignment occurs when the internal circadian clock is not properly aligned with the external environment, including light-dark, sleep-wake, and fasting-feeding cycles. Example of which is acutely with jet lag or on chronic basis with shift work, delayed sleep phase, or advanced sleep phase disorders. Night shift work is an example of severe circadian misalignment as workers are awake, active, and eating during their biological night and trying to sleep and fast during their biological day. Circadian rhythm disorders may affect the adrenocorticotropic hormone, cortisol, and of course, TSH. Delayed sleep phase syndrome is a disorder in which a person's sleep is delayed by 2 hours or more beyond what is considered an acceptable or conventional bedtime. The delayed sleep that causes difficulty in being able to awake at the desired time. So the effects of DSPS is that in hormonal rhythms were delayed in patients with DSPS, although there was no difference in the total 24-hour secretion of TSH and cortisol when compared to control. As you can see on the illustration on the left, this is cortisol secretion showing normal alignment of circadian rhythm on in green and misalignment in red. Okay, there's abnormally high cortisol levels, which has also been noted at the end of the wake and start of sleep. This could contribute to insulin resistance and hyperglycemia. So circadian rhythm disorders also affect insulin, glucose metabolism, and appetite regulation. Investigators found that the primary effect of a phase shift, whether phase advanced or phase delayed, was a combined disturbance of glucose insulin metabolism. Glucose concentrations were higher without any concomitant change in insulin concentrations. Acute circadian misalignment results in increase in postprandial glucose and insulin levels with a concurrent decline in leptin levels. So what happens is that there is an increase in appetite coupled with decreased energy expenditure, which results in increased risk for obesity. In the nurses' health study, researchers found that subjects who worked rotating night shift had an increased risk for diabetes, and even after adjusting for traditional diabetes risk factors, including BMI, the risk was still noted in these shift workers. Circadian rhythm disorders were also noted with melatonin, gonadotropin, and oncogenic effects. Shift workers may exhibit altered nighttime melatonin secretion and reproductive hormone profiles that could increase risk for hormone-dependent cancers like breast cancer. So in circadian rhythm disorder, there is a reduction of melatonin in delayed sleep phase syndrome, which will result in increased LH and FSH and eventual increase in estrogen and testosterone. Melatonin also have been found to have a tumor suppressive properties, and this anti-tumor effect may be due to its direct effect on hormone-dependent proliferation through interaction with nuclear receptors, an effect on cell cycle control, and possible increase in p53 tumor suppressor gene expression. There are also endocrine abnormalities resulting from disorder of hypersomnia. So limited data exists regarding hypersomnia and associated endocrine abnormalities. Patients with narcolepsy are often obese and have been reported to be at increased risk of diabetes mellitus, though other studies using BMI match control have not shown any increased risk of type 2 diabetes or impaired glucose metabolism independent of BMI in narcoleptic patients. So with that, hopefully I was able to go through the three objectives given to me. And in summary, let me say that sleep quality and quantity is important in maintaining hormonal balance. Disrupting this balance can have significant health consequences. Abnormalities in the endocrine system can lead to significant sleep disruption, and treating these hormonal abnormalities can improve sleep. And lastly, poor quality or insufficient sleep can have a major impact on hormonal balance, like insulin and glucose metabolism, as well as on appetite regulation. With that, thank you very much for your attention.